Sowmya, may I request Dr. Sowmya now to start her presentation on newer updates on amblyopia therapy. Sowmya is a consultant pediatric ophthalmologist at Shankara Group of Hospitals. She's based in Bangalore, and she has had a lot of work done in strabismus as well as amblyopia. Welcome, Dr. Sowmya.
Thank you, ma'am. At the outset, I would like to thank the AIOS and the ASPOs for the invite. Thank you, ma'am, for the invite again. This session is titled very beautifully. What I did differently in 2022 with respect to amblyopia that I will be speaking on. My talk would basically comprise of understanding what are the newer understanding in amblyopia, what are the improvised tools and diagnosis, our own innovation here in terms of Kanna photo screener using the AI technology, the newer methods of treatment, our work in binocular therapy, and a few of the theses work which are in the pipeline. So the newer understanding is basically that we now know that the amblyopia is a binocular disorder, not a monocular disorder, and the intact binocular processes are not lost, but they are just suppressed in amblyopia. So it basically is a functional monocularity rather than a structural monocularity in case of amblyopes. It goes on to say that the degree of neuroplasticity persists well beyond the sensitive period as we thought earlier, and that can be restored. So what are the improvised tools and diagnosis? Primarily for diagnosing amblyopia, you need to pick up the amblyopia risk factors in terms of either strabismus or in terms of refractive error or media opacity. The newer thing in the block is the blink vision screener, which basically is based on the birefringent property of the Henle's layer. And the rays of light which comes back reflected from the Henle's layer would have a specific frequency versus those which come from the parafoveal area, and thus can pick up microstrabismus in these patients and thus pick up the amblyopia risk factors in terms of amblyopia. The ones who have designed this also claim that even in case of refractive errors, that these prove better as photo screener compared to the those based on infrared rays. Well, our own work on this field has been the deep learning and the image processing based on image processing analysis, basically uses a smart and combines the phase and detect both the refractive errors using corneal light reflex, the media opacities in terms of dim illumination with the red excitation, based on these data points which are there. So we looked at this as a photo screening device, use the same thing for validating the instrument in nearly 654 patients, which gave us a sensitivity of around 83% and 94% of specificity. Almost all the factors, though we had done this work a little earlier than COVID. So we had used a 2013 guidelines, 2019. We had difficulty in picking up isometropic amblyopia. And so the principle based on action of lateral inhibition or rule of based cognitive learning. There are a lot of criticism against the perceptual learning in terms of what is gained on the screen is translated into the novel situation or into the practical criteria. And the need for home-based training system again limits perceptual learning. Unlike the binocular therapy, where it could be based on anti-perception therapy, use the stimulus only for the amblyopia and not use any it can be based on dioptic therapy, IVET system, or a virtual reality headset, so a balanced binocular viewing, or monocular fixation in binocular field, or a passive binocular therapy. Dioptic therapy, it can work either at the cortical level or elevating suppression or by the contrast attenuation, unlike the IVET system, which is basically based on using shutter glasses, which kind of alternate at such a high speed that it gives an enriched image only to the amblyopic eye. We've got various studies which have looked at various aspects of it. What we know is no level 1 or level 2 evidence telling that there is definite improvement in the sensory status using a binocular therapy. And there are also challenges in terms of age included, the types of amblyopia included in various studies, and the need for more engaging games, and what happens to the visual acuity post-cessation. The implication is also that whatever improvement is seen in the stereo acuity does not correlate with the intraocular visual acuity difference. So probably the stereo acuity gain is not exactly working in the terms of improving the visual acuity per se itself. What our experience has been that we did a thesis work on this using a dichoptic therapy with a monocular fixation in binocular field, taking into consideration only in anisometropic amblyopes between 8 to 40 years of age. They did a gaming duration of around 30 minutes a day, 7 days a week for around 42 sittings. We also looked at not just the visual acuity, but also at contrast and visual sensitivity. This is basically the matching patterns which is used for as a part of binocular vision therapy in a visual prime, which is basically another device of VTS. When we looked at the number of subjects, we had more anisohyperop amblyopes because we had excluded most of the mixed combination mixed amblyopia group. We found a significant improvement in both distance visual acuity and near visual acuity. What was also interesting was the contrast sensitivity in the amblyopic eye also improved with time, and the stereo acuity again improved. But there was again no correlation between the stereo acuity and the visual acuity improvement which we saw. We had a little challenges in terms of patients we were lost for follow because in between the COVID, so we couldn't get up as to when they stopped the treatment, what happened to the visual acuity. With whatever limited data that we are aware of, in those patients, there was no regression of the therapy or regression of the visual acuity improvement post-op visual therapy. What is in pipeline? There's a recent study which is published from China, which talks about asynchronous it's something like an IBED therapy itself. The experimental drugs either targeting the excitatory or inhibitory synapses or neuromodulatory systems, or those which look at HDAC inhibitors as well. Or the environmental changes, the recent study which has been published on transient dark exposure, especially in mice, and they looked at neural activity post dark exposure. There is 7 days of dark exposure, and looked at the neural network which can be done in live mice itself, and found that the new neural networks have been re-established. So that may be something that could be tried, or the next thing. What we are looking at is software which is based on virtual reality in amblyopia. This is one of our optometry college faculty's topic research work that she is doing on. This is based on both the things that we have combined a monocular fixation and a binocular field. This is basically the first 10 seconds of the game where the child uses the virtual headset, and any Android phone can use this software, where the amblyopic eye is used or stimulated with this grading pattern, what you see, which correlates with the visual acuity or the pre-existing visual acuity of the patient per se. After this 10 seconds, it switches to the dichoptic mode, where the contrast sensitivity between the amblyopic and the non-amblyopic eye is utilized for stimulation. And the last 10 seconds again switches back to this. So they play around, and this alternation, they play around 20 minutes a day, 6 days a week for the next 3 months, and then look at the visual acuity improvement. So where do we stand now? We don't have an exact answer for what is a perfect photo screener. With the infrared photo screeners working well for a refractive amblyopic risk factors, and the other is other like a blink photo screener or an easy photo screener for microstrabismus. Do we use binocular therapy or a primary or a GINC modality? What is the timing? What is the optimal duration? Does it apply to all types of amblyopia, especially in terms of sensory deprivation amblyopia, where we don't have answers yet? Dose response relationship or individual variability. So again, there's no level 1 evidence to say that this can be used as a substitute, but definitely yes, in those of adult patients that are resistant to treatment or refractory to treatment can be a useful modality. So to conclude, explore the numerous ways to get rid of laziness, either in terms of penalty, patching, or gaming. We are near, yet so far from saying paradise lost and paradise regained. Thank you very much for the opportunity. Apologize for on and off.
Do you try this age-old